Hi, this is Megan Donito, and I chose to focus on the health belief model for our theory project. The history of the health belief model, it was actually one of the first theories of health behavior, one of the first models that predicted what motivated health behavior. It was developed in the 1950s by US Public Health Service social scientists. Their purpose was to try and explain why people were not engaging in programs to prevent and detect disease. What had happened was they had noticed that when free x-ray services were offered for tuberculosis detection among a population, there was a very low turnout. So it sparked their interest as to why that was. So they conducted some research and theorized that a person's perceptions susceptible of how susceptible they are to disease and perceptions of benefits obtained if they're trying to avoid the protective health behavior influence their willingness to act. Researchers then expanded on the theory over the following years and developed a total of six constructs, which determine one's ability to take action in preventing, screening for, and controlling disease. And here's the progression of the HBM or health belief model. The original constructs are on the left, and they are perceived susceptibility, perceived severity, perceived benefits, and perceived barriers. And on the right, the two additional constructs which were added to increase predictive power of the model. They were added in 1988, and that's cues to action and self-efficacy. And we will talk about all of these in just a moment. The application of this model to public health interventions really used in addressing behaviors that cause health concerns or increase risks. For example, unsafe sex practices, smoking, or drug use. And it's applied in order to promote engagement in health protective behaviors such as screenings, healthy eating, healthy lifestyle, exercising, medication compliance, vaccine uptake, etc. Here are the constructs of the HBM. On the left, I have the concepts and their definition down the middle column, some potential change strategies, and then on the right, I wrote some examples in that would be applied to the example of vaccine uptake. So on the left, we have perceived susceptibility, and that is the belief about the chances of getting a condition. So um, how likely am I to get the flu if I don't get the vaccine, for example. Um, an intervention example with that would be really to break down the reasoning that leads to a decreased perceived threat. So perceived threat really comes from this perceived susceptibility concept, and we'll talk about that a little bit more as well. But really, you'd want to offer education to impact a person's awareness, which is a modifying factor, and we'll learn in a moment that modifying factors can impact some of these concepts. Um, so there's an incredibly high contagion rate of said illness if you do not vaccinate. If you contract the illness, you may become seriously ill. Would be an approach is just offering that knowledge and that awareness that um, there should be a heightened sense of susceptibility to the disease in order to promote the health behavior. Um, Next concept is perceived severity. So this is beliefs about the seriousness of a condition and its consequences. So how serious will this be? How serious will this flu be if I don't receive this vaccine anyway? Uh, you'd want to specify the consequences of a condition. So basically, there's something called fear appeals, which are persuasive messages. This is just an example of one intervention here, but fear appeals are persuasive messages highlighting negative outcomes. For example, advertisements of sick individuals who did not vaccinate via TV ad or radio ad. It's a way to to show just how serious this would be if you don't take action. So the action is the endpoint for the health, or actually carrying through with the health behavior, and that's what we want to happen. Um, Perceived benefits is another concept. These are beliefs about the effectiveness of taking action to reduce the risk or seriousness. So again, you want to highlight the net gain and really break down barriers here, because a person, the HBM says that a person goes through mental math, basically weighing perceived benefits and perceived barriers, which is the next concept underneath that, which is beliefs about the material or psychological costs of taking action. So I'm going to do a cost versus benefit analysis. I'm going to weigh how effective of taking action, how effective is this vaccine going to be, what are the gains here, what are the net gains I'm going to get, and I'm going to weigh that against any barrier. So is it a cost issue? Is it an access to care issue? Do I not want to take time off of work in order to get this vaccine? So again, this is where we want to highlight the net gain and break down barriers, offer the vaccine at a clinic close by or a workplace to avoid taking time away and ease access, offer a no-cost vaccine in order to get that person to the end point to engage in that health behavior, excuse me. Cues to action, we're down toward the bottom with cues to action and self-efficacy. These were the two constructs added in 1988. Cues to action are factors that activate a person's readiness to change. So this is where you want to provide how-to information, promote awareness, employ reminder systems. For example, reminder text messaging, email, and posters to advertise a vaccination event would serve as a cue to action, um, to predict that I would say go to this event and get my vaccine. Self-efficacy, confidence in one's ability to take action. You want to provide training and guidance performing the action, um, so that the person is confident that they can carry through with this action and get to this endpoint. Verbally reinforcing language is good here. For example, you can easily protect the health of yourself and your loved ones by getting vaccinated in under only 5 minutes. Excuse me. So that's one example there. This is my infographic on the health belief model on the right. On the left, I chose to lay out two uh, two constructs that are combined to formulate perceived threat. So perceived severity and perceived susceptibility combine, or have I shouldn't say combine, but have an influence on perceived threat. So perceived threat is formulated by those two constructs: perceived susceptibility on the left and perceived severity, which we talked about those definitions on the previous slide. And then we have perceived benefits or expected net gain, person's belief in the effectiveness of the health protective behavior, perceived barriers, person's belief about negative aspects. And again, a person will engage in that mental math at this point to perform a cost versus benefit analysis. They want to maximize their outcome while minimizing the costs. So modifying factors also come into play. Um, Modifying factors are age, gender, race, knowledge, or socioeconomic factors, etc., that can, quote, moderate or influence the constructs of perceived threat and the expected net gain. Up at the top of the infographic, perceived threat, I should have mentioned this before, has some asterisks around it, and so does perceived benefits down toward the middle. Those two are really being weighed, or those two are the primary constructs, excuse me, in this model. And then the weighing of the barriers and benefits. So the modifying factors, they can influence some of these constructs, and cues to action are used as the interventions. Cues to action can also be external, like events or reminders, or internal. So if you have a symptom, if a person experiences a symptom that worries them, that might prompt them or be a catalyst for them to take action. And self-efficacy, again, is confidence in one's ability to change or perform a health behavior. And we want to be sure that one feels confident that they can be successful in that health behavior. Two main constructs act upon the behavioral endpoint: perceived threat and perceived benefits, or expected net gain. Just illustrated that more there. Um, so the endpoint is a likelihood to take action if the net gain is perceived as enough. Here's some more relationships among the constructs. Um, on the left, you have level of perceived threat in the circle, and then some things are pointing to that. Perceived severity, perceived susceptibility, modifying factors can also influence uh, perceived threat and cues to action. Again, an example is if I feel a symptom that scares me, that can serve as a cue, an internal cue to action and increase that perceived threat. And then on the right, we have modifying factors: age, knowledge, socioeconomic status can impact perceived benefits, expected net gain, self-efficacy as well. Um, excuse me. And again, that also influences the endpoint. First case study, the purpose was to examine two different HBM-based interventions to increase attendance at follow-up appointments among patients who had hypertension. They were referred by their emergency department doctors in a 500-bed acute care private hospital in Ohio. The study reports on 72 patients who visited the ER with hypertension. So again, we're looking at using this intervention to be sure that these folks with hypertension were compliant with their follow-up recommendation. The following inclusion criteria were established: blood pressure above 90, treated or untreated, did not require inpatient hospital admission, had a referral follow-up recommendation by a board-eligible physician with 10 years experience, had a telephone in their home. The dependent variable here is compliance, making a follow-up appointment with a healthcare facility based on referral and keeping the appointment. So making and keeping is what we're looking at. Um, Variables assessed for association with compliance. Okay, so we looked at patients' knowledge of the disease. Scores were given 0 to 3, 3 meaning they had the most knowledge, they were very knowledgeable about their disease process, 0, not so knowledgeable. History of past treatment of the disease, so have they treated themselves in the past, and whether or not the physicians rated their disease or their hypertension as serious or not so serious. Um, and this was based on the HBM's construct of perceived severity. Complexity of treatment was rated on the ordinal scale. So did they have to do one behavior? In other words, did they just have to take medication in order to control this? Or did they have to take medication, change their whole diet, take one medication, take multiple medications? How complex is it for these folks to manage the disease? The independent variable was a clinical intervention based on the HBM in three parts. Part one was assessment of the patient's perceived susceptibility, standardized interventions related to the patient's perceived risks, and part three was patient education, information specific for their acute hypertensive episode designed to increase perceived susceptibility to complications and benefits of taking action through follow-up appointments. So again, they were educated on, look, this is, um, you really need to follow through with this appointment for your health. This approach was modified for each patient depending on their knowledge level. So some patients needed more in terms of intervention here. Dependent variable two, this was very similar to the first one that I just talked about on the previous slide. This is just a shorter version consisting of a telephone call by the research nurse. So instead of a face-to-face appointment, really delving into all of these things, the research nurse made a quick phone call. They were asked if they had made a follow-up appointment, and they were dropped from the study if the answer was yes, as making the appointment could not be attributed to that actual phone call. But while the nurse was on the phone, she did a shortened version of the previous slide, just reminding patients to go and did you do it? Procedures and intervention delivery, they were randomized to one of the four groups below. All of them received routine nursing care at their visit in addition to this. But control group A, no follow-up HBM based on, no follow-up health belief model based telephone intervention. Okay, that was the control group. The experimental group B, follow-up HBM based telephone intervention. Experimental group C, HBM clinical intervention was applied during the visit and no follow-up intervention on the phone. And group D, they had both. They had clinical intervention at the visit and the follow-up telephone intervention was made. Results are here. There was no apparent association between age or other demographic variables and compliance. The degree of knowledge about hypertension or past treatment history was also not associated. Logistic regression was performed on each of these variables. Notable findings, the HBM intervention was statistically significant in predicting, making, and keeping follow-up appointments. Each of the HBM interventions were equally as effective on compliance with similar impacts, 50% increase in making an appointment and 40 increase in keeping. 50 in making, 40 in keeping. Excuse me. Patients whose blood pressure levels were rated as, quote, more serious were likely to comply with follow-up appointments, and those whose levels were rated, as less serious. Essential components of both interventions included increasing perceived susceptibility to hypertension complications and providing educational information on benefits of taking action. Pros and cons of the intervention in this particular study. It increased the patient's perceived susceptibility to complications of hypertension and focusing on the modifying factor of knowledge, because again, that is a factor that can impact perceived threat through provision of educational materials concerning benefits of action proved to be successful. So that intervention, focusing on those two things, benefits of action and perceived threat, really proved to be successful. The cons, interventions limited as it did not consider all environmental or economic factors that may prohibit or promote follow-up appointments for hypertension. Case study 2, the purpose here was to determine whether interactive text messages based on HBM constructs improve rates of clinic attendance, postpartum, and early infant HIV testing in the Nyanza region of Kenya. So ultimately, the goal here is to improve the retention of mothers in mother-to-child transmission programs of HIV in sub-Saharan Africa. Only 28% of such infants in low and middle income countries were tested within 2 months of birth in 2010. So a parallel group unblinded randomized controlled trial was conducted here. Women at least 18 between 28 weeks gestation and delivery were recruited from among HIV positive women attending an antenatal clinic or HIV clinics at 5 health facilities in a mix of rural and urban settings. There was 388 total women randomized into 2 groups. Intervention group, they received two-way tailored SMS text messaging based on constructs of the HBM, and a control group who received no text messaging, just typical standard one-to-one care in the clinic. Focus group discussions with health workers and women attending antenatal, postnatal care, and prevention of mother-to-child transmission clinics. And HBM constructs guided these focus group discussions. So there was focus group discussions, and intervention text messages were based on key themes from those focus group discussions. So we started with focus group discussions. The women were then followed through their pregnancy with 14 messages. Up to 8 were sent during pregnancy, and additional messages were sent weekly for the first 6 weeks after delivery. And again, these messages went both ways, so the women could also text back. Participants in both arms were allowed to call or send SMS to the study nurse at any time. Study staff called participants in the arms weekly, beginning at 38 weeks gestation, to ascertain whether delivery had occurred or not. So they really wanted to encourage these women to go back after the delivery of their babies for care, not only for themselves, but to get their babies tested for HIV. Results were significant. 0.6% of the women attended postpartum clinic visits as compared to 11.8% in the control group. And in the texting group, 92% of the infants had testing as compared to 85.1% in the control group, which is substantially higher than the 39% observed in Kenya overall at the time without any intervention. Pros and cons here. The SMS messages seem to serve as a powerful cue to action for the women in this study. Modifying factors were taken into account as text messages were individualized based on recipient's age, name, preferred time, language, date of delivery, and infant's name. So it was really personalized. The cons, difficult to determine what aspects of the HBM led to the efficacy, and it's not clear which constructs of the HBM were utilized in the development of the text messaging. Um, so that the part was vague in the study. General strengths and weaknesses of the HBM overall. Um, Strengths are, simple constructs, easy to implement, widely used to predict health behavior, useful constructs. Weaknesses has not been found to predict risk reduction behaviors that are socially determined or unconscious motivations, does not consider environmental or economic factors, does not address important factors like the impact of social norms and influences on behavior and other social influences on behavior. No clear correlations or formula between the constructs of the HBM. In summary, the HBM model can help guide intervention for risk factors such as low perceived severity and susceptibility. However, it leaves a gap through its lack of consideration for behaviors that are occurring habitually, like smoking, socioeconomic factors, influence of social norms, and environmental factors. It's descriptive but not explanatory. For most effectiveness, it should be used in combination with other theories that take into account environmental factors, such as the theory of planned behavior, which addresses attitude and social norms, social cognitive theory, which encompasses cognitive, behavioral, personal, and environmental factors on behavior, and theories of automatic behavior and habits to focus on habits, automatic activation of attitudes, and contributing environmental influences. Um, Thank you so much, and these are my references. Thank you for watching.